Hello everyone, Dr.Jyotsna here. So my question is, suppose you are suspecting pneumothorax on a X-ray, and so how you are going to proceed with the management of the patient. So let's start. If you see or you have a suspicion of pneumothorax on X-ray, first you have to go, and if the patient is on mechanical intubator and mechanical ventilator, means on positive pressure ventilation, you have to increase the FiO2 to 100% and decrease the PEEP if it is intubated and mechanically ventilated. Also decrease the pressure support and tidal volume. If the patient is not intubated but is on NIV, non-invasive mechanical ventilation, either through this non-invasive mechanical ventilator, through the mechanical ventilator or portable ventilator, either way, if you can take out the NIV mask, take it out and put the patient on NRBM with the full flow, means 15 liter flow. Okay, so why we are doing increasing the FiO2? Because we want to denitrogenize the air inside the lungs. What it will do? When we are giving 100% FiO2, we know that air has got 21% of oxygen only, and most of the component of air is nitrogen. So if now instead of 21% of oxygen in the air, if the patient is breathing from 100% of oxygen, then what will happen? The air which is in the pleural space, which has got 21% of oxygen, and most of them are nitrogen. This nitrogen, because of the gradient of the lesser nitrogen in the inhaled air, this nitrogen will come and out from the lungs and it will go to the air. So there will be the washing out of the nitrogen, along with that air will also wash out. So this is the way the air can be absorbed. The pneumothorax can get resolved. But so this is the thing, this is the funda behind giving the FiO2, 100% FiO2 to the patient if we are suspecting pneumothorax. Another thing, why we are decreasing PEEP? PEEP, positive and expiratory pressure. So this PEEP can increase the pneumothorax further. So that's why we are decreasing it. Pressure support also, or tidal volume also, that is also we are giving the air is going inside, so pressure will increase, so it decrease that also. In the same way, pressure support is also we want to decrease the pressure. That's why we are decreasing the pressure support or putting off the NIV. So if the patient is on NIV or positive pressure ventilation, if the patient is intubated, especially if the patient is intubated and mechanically ventilated, means invasive mechanical ventilation, and there is a pneumothorax, even a small pneumothorax, you have to put ICD because of the positive pressure, it will expand, and till the patient is intubated, you have to keep that ICD in situ, and once the patient is extubated or off mechanical positive pressure ventilation, you can take out the ICD. So our second thing, if the patient is not on NIV, not on invasive mechanical ventilator, and patient is on room air and there is a pneumothorax, in that case you can just put on NRBM 15 liter of oxygen. Through that you can give to help to denitrogenation of the air. So this you can do. Another thing, the second thing, if the patient is on invasive mechanical ventilation, you have to push the ICD, even the small pneumothorax. If the pneumothorax is big, or if the pneumothorax size is small and the patient is not intubated, the patient is on room air, in that case conservative management can be done, and we have to find out the cause, whether it is a iatrogenic or because of any trauma, or whether it is secondary because of the patient is COPD or asthma, having bulla, or intrathoracic pressure has increased for whatever reason, or there is some bronchogenic carcinoma, we need to find out by doing the CT scan if it is small. And if this pneumothorax is causing hemodynamic instability, means there is a tension pneumothorax. How we say it is a tension pneumothorax? If a pneumothorax is causing hemodynamic instability, decreasing the venous return, because of the increase in intrathoracic pressure, and which is leading to decrease BP and hypoxia. You will see that in physical examination the patient will be dyspneic, the trachea will be shifted, pushed toward the opposite side, and medicinal there will be medicinal shifting, so the apical heart sound will be heard on the it will get displaced or pushed up. It will be pushed, basically whichever side there is pneumothorax, it will push to the opposite side. So that is the thing. So there will be diminished air entry on percussion, there will be the movement of the chest will decrease, there will be a resonant sound on percussion. So these things on auscultation you will get, on physical chest examination you will get, or if the patient is on mechanical ventilator, you will see that there will be peak airway pressure, increase in peak airway pressure, and plateau pressure. So plateau pressure has increased along with increase in peak airway pressure. Sudden this has happened if the patient supports, or the patient is on intubated and mechanically ventilated, and suddenly someone calls you and say that there is an alarm going on, or you see that the alarm, there is a increase in peak airway pressure and plateau pressure, and there is a desaturation. So you have to immediately, there should be suspicion of pneumothorax, and if you can check it through that auscultation and on physical. Along with that, you can immediately do a ultrasound. What you will get in ultrasound? In ultrasound, you will see that there will be a profile. There won't be any B line. If there is a B line, the pneumothorax rule out. If you find there is a lung sliding, means the lung sliding is there, pneumothorax is ruled out. But pneumothorax, if they are finding a lung sliding in one place, you have to see in all quadrant, okay? Because there can be pneumothorax in one place, and there may not be it may not be a full pneumothorax. So the place where there is no pneumothorax, that place there will be a lung sliding, and where there is a pneumothorax, there will be no lung sliding. And the best way to its confirmatory sign is that if you get a lungs point means where there is a place where in half side you will see there will be a lung sliding, and another side you will see no lung sliding. Where there will be lung sliding, there will be a barcode sign, okay, and a seesaw sign will be there. When there is a lung sliding, there is a seesaw sign, and where there is a no lung sliding, there will be a barcode sign. So this you will see. And if you see a transit area, that is the lungs point, then it is confirmatory of pneumothorax. But it is very difficult to get a lungs point, okay, because for that you have to scan the whole lungs properly. So but the tension pneumothorax is basically a clinical diagnosis. In that case, if the patient, there is a tension pneumothorax, earlier we used to put in second intercostal space, mid axillary line, but now it is not recommended. It is we put in fourth intercostal space anterior to the mid axillary line. There we put the drain. Immediately you have to put the drain. You can do X-ray also, bedside X-ray also, but generally the focus is well enough, you can see on that. If you are not used to, then you should get used to for that. And other than that, after stabilizing, hemodynamically stabilizing, you have to find the cause. For that, if you know that it is iatrogenic because central line or because of particular, you already know that there was a bulla and patient, we have put a patient on positive pressure ventilation, that could be the cause, and it's okay, you know the cause. And if you don't know, then you have to find the cause by doing the CT scan accordingly. Thank you.